Okay, thank you everyone for joining. I'm glad that we were able to get the Telewell webinar series back up and running. So this is the first of a two-part series, Sustaining Care. And next week on Wednesday, Mr. Albert Tittman will be delivering a webinar, Sustaining Ceremony, I believe it is. And he'll kind of talk about sustaining tradition during COVID-19 and going forward. So the outline of this presentation is, first I'm just going to kind of briefly go over some of the things that we learned, Telewell and more largely Springer Behavioral Medicine, through the transition to the provider to patient direct care during COVID-19. And then Katie Bell is going to take over with sustaining care for our patients with OUD and SUD in our tribal and urban Indian health settings. So the timeline of COVID-19, we really first started hearing about it at the end of January. That was the first COVID-19 case in the United States, and that was here in California. Things really changed for us in this field with the public health emergency declaration by the Secretary of Health and Human Services. And that allowed for some of the previous regulation and practices to be amended to meet this public health emergency. Some of the guidance around the beginning of March, we received guidance from SAMHSA, Department of Healthcare Services, HHS, and the Governor of California wrote an executive order allowing for the provision of services direct to the patient at their home, and some of the regulations that would normally accompany an in-clinic visit were eased to make sure that we can practice social distancing and just facilitate that transition to direct care. So one of the first challenges that we had when we made this transition was communication. We initially, like straight off the bat, we had everyone do telecommuting in our practice and working from home, and so communication was a challenge. We got staff cell phones for all of our staff that would be doing any kind of patient communication, our case managers and schedulers. And we instituted daily team meetings. Originally, we had been doing weekly meetings for each sub-team, but we realized that, with people not being able to communicate in the office, it was important that the entire team get together, the whole company, every day and discuss what needs to be done, and particularly make sure that all the patients are receiving the care and scheduled appointments, that sort of thing. One of the other hardships was patient communication. It became more challenging with everyone telecommuting and with patients not, showing up to the office. It became more challenging to communicate effectively with them. So one of the first things that we did is we put a website notification on our website, a banner that informed everyone that our offices would be closed. And it actually gave a link for how they could join a telemedicine session right there on the website. And then we updated our answering system here at our clinics to provide all of the phone numbers for the staff members that were working from home. One of the things that we ran into over this period is we had a significantly increased no-show rate. And I think that that's largely due to the fact that folks just don't have the same level of interaction when they're not coming into the office. We actually had a number of people say that they just forgot because they're not coming into the office. It's not something fresh in their mind of an appointment they have. And so they get caught up in other things and they just forgot their appointments. One of the ways that we mitigated that is we instituted auto reminders through our EHR And that's a really effective way that sends them out a text message or an email letting them know about their appointments. And then we increased the patient calls. We delegated more staff to reaching out to patients for appointment reminders and scheduling, and we increased those staff's hours to meet that need. We instituted an online patient portal through our EHR, and that's been really helpful because the patients can go on there and they can actually reach out to the providers or schedule appointments right within the portal. One thing that's important to note is that it's necessary to get the consents for text and phone message if you're going to institute the auto reminders or the patient portal. We also upped our IT support. So a couple of things that we did that were pretty effective for the IT support, which is much more important during this period, is we set up a troubleshooting protocol, and we basically listed all of the different issues that we run into with IT, and we set up a chain of escalation so that all the staff that would be interacting with patients, they're familiar with and can address the simple IT problems, turning on the camera, getting logged in. But then there was actually particular issues that if that was encountered, they would actually send it over to our dedicated IT support. Initially, we had a lot of people were just going straight to IT, and he became overwhelmed. So we went ahead and educated our staff on the simple issues and then set up a structure for escalating that. We found that Google Voice or some of the other VoIP services are a really good option to allow people that are doing telecommuting to be able to have a phone number that can be reached by patients. We've used that very effectively. And then a lot of programs, like we use DoxyMe for a telemedicine platform, and on a lot of, particularly the medical platforms, the support and the technical support notifications is really, really good. So anytime that there's an issue, which as COVID-19 started taking off and a lot more people came onto the platform, there was reoccurring issues. It happened quite frequently, but they were very good at sending us out notifications and letting us know that they're going to be down during this period and this period, or letting us know what fixes we could do. And one of the other things that was effective was to actually schedule a test call with every patient that is doing telemedicine from their home for the first time. We would have our IT support actually reach out on a non-clinical day and actually just initiate a call with them under our admin profile, and that was very effective. The main technical issues that we ran into when trying to implement this was the camera and mic not working, a poor appointment setting. And this, we kind of thought it seems like a no-brainer that you would want a quiet and private setting. But we actually had a number of patients initially that were doing their appointments on their work break in the lunchroom, or that were doing their appointments while driving down the road, or at home. So we quickly addressed that and let all patients know that, treat this appointment as you would any other appointment. It should be in a quiet, private setting. And it's important to turn off home assistants like the Amazon Alexa or the Google Assistant, because those actually are activated by voice. They're always listening. So for privacy issues, we ask them to turn those off. Unstable connections was another issue that we ran into. And then just lack of access for devices. The best devices to use go in order of a laptop, then a smartphone, then a phone is the last case resort. The laptop's always going to provide better quality and a more realistic experience. If a lot of folks didn't have access to a laptop or Wi-Fi, so we get them on the phone, on their smartphone. And then there was a couple of patients that don't have either. And if that's the case, the last case resort would be to just actually do a telephone call with them. For the main problem, the camera and mic not working, this was by far the main issue that we encountered. It was 90% of the time. The camera wasn't accessed by the platform, or the microphone wasn't accessed by the platform. Apple was kind of notorious at that. They would do updates, and every time they would do an update, they would change the privacy settings and make it so that other apps couldn't use their microphone and camera. Or one of the other issues is a lot of times if people are on their smartphone, if they receive a call during that telemedicine session, it'll actually get rid of the access with the camera and the microphone. So a couple solutions to that was creating a simple troubleshooting document that we can send out in an email to every patient so that they can kind of help walk themselves through the process. 90% of the time, if they just disconnect and then reconnect and turn off the camera or mic being used by anything else, it solved the problem. If that didn't work, we have an admin account so that we can have our IT person actually schedule a call as if they're a provider and make sure that all the details are worked out. And then our telemedicine platform has a pre-call test tool, which is a really great feature. It's one of the advantages to going with a healthcare-based telemedicine system rather than using a different online platform, because this tool will actually go through and troubleshoot the patient's connection and walk through everything and let our IT know what's the issue and how to solve it. As far as unstable connections, which can either just be, insufficient internet, or sometimes, there's other issues with the connection, especially, with everyone joining online meetings during COVID-19. For a laptop, one of the solutions to that would be to have them plug it in with an Ethernet cable. One of the other ones would be to find the location in their home with the strongest Wi-Fi. Some people actually aren't aware that the Wi-Fi is a lot better at one place in your home than the other, generally next to the router. And then reducing the settings from HD to standard will often completely fix the problem, and you won't get the lagging, and you'll have a stable connection. For phones and tablets, one of the main ones is to stay stationary. A lot of times people want to walk around with the phone or the tablet, and that makes the connection very difficult. In addition, as it's moving around, the information that has to be transferred is a lot higher, so that it makes it a lot more challenging on the connection to transmit that information. So one of the things we started doing is just asking patients to set their phone down. There's a tendency to want to pick the phone up and look at it and get closer to the provider, but we ask them just to set the phone down on the table, and the connection will always be better that way. And then sometimes when the audio connection just won't come through, we actually instituted simultaneous calls. So we would call the patient on the phone and use the video from the telemedicine platform, but call them on their phone. And that was a good workaround for that. Some of the clinical issues that we ran into, one of the main ones that was reported was increased anxiety. And that kind of, doesn't need further explanation. During this time, a lot of our patients had anxiety about a gambit of different issues. We did notice increased relapse, and a lot of patients cited that it was, limited support from friends and family and other support networks, a lack of accountability. I guess the telemedicine to some degree, not coming into the office, made some feel like they weren't quite as accountable, or certainly that would be true for other groups or recovery meetings that they were normally involved in, but now they'd shifted to online. And then a lot of our patients, lost their insurance or their ability to self-pay with the loss of their job, and so that was a factor in the increased relapse. And then one of the other issues we ran into was non-compliance with the treatment plan. Some of the solutions that we have for that, for really those three, would be suggesting more online meetings. As COVID-19 took off, a lot of recovery resources popped up online. There's all sorts of meetings that they can join, and just suggesting that they take those opportunities. If they can't do an in-person meeting, do more online meetings. For the anxiety, our providers suggested more exercise and meditation and strategies to kind of keep the anxiety down. And then for a lot of folks, more frequent visits was what the providers thought was a good idea. Um, Now, one of the things that did happen is guidance came down that to aid in social distancing and decrease um, people's trips to the pharmacy or to a clinic, that longer prescriptions could be written, and up to 3 months between visits. And so for some folks, for some stable folks, to kind of in aiding the social distancing, that was employed. But for a lot of folks, we actually found that it was important to have more frequent visits because of all the stress going on right now, that they actually need more frequent visits. And telemedicine does definitely help that. One of the other issues that we ran into is a lot of patients anticipated a medication shortage. That was one of the common things that we had kind of expressed to us, was that there was a real fear that they would not be able to get access, particularly to their buprenorphine. Fortunately, we have not found this to be the case. We have not run into a medication shortage on our end yet. But that was actually the impetus for a lot of the 3 months visits, at least on the patient side, is they wanted to make sure they had that medication for 3 months. One of the other issues that we ran into, and I know this has come up before, and I think Katie will probably touch on this again, would be vitals and urine drug screens. How are those collected with a telemedicine visit? And there's a number of different ideas that are tossed around, such as a point of care saliva test, or actually having a lab test done. But I'll let Katie kind of touch on those more. One of the final things for the clinical issues that we ran into, that was kind of initially an oversight, was that for a lot of these patients, their pharmacy information changes if they're doing an in-home visit. A lot of these folks, the pharmacy they have listed is the pharmacy that's close to the clinic in town where they go. So that was one of the things that we had to immediately jump on, was at each appointment, update all of the patient's contact information, and most importantly, update the pharmacy information. We ran into that issue a number of times because a lot of these folks are driving 30, 60 minutes to get to their in-person appointment. And so generally there's a pharmacy a lot closer to home. And I think with that, I will go ahead and load up Katie's slide set. So thank you all for listening to me, and let me get Katie's slide set going. All right, Katie, please take it away.
Okay, so will you
control the slides?
Yeah.
I will.
Control the universe while you're at it. Hi, everyone. Just happy to see who's here. This is probably me singing to the choir. And I can barely carry a tune. So, but I wanted to really kind of explore very specifically what's going on in our tribal and urban health, Indian health settings in the context of COVID and the challenges. So I'm going to kind of move through these quickly, and I would just love to hear your thoughts and input as afterwards. All right, next slide. So this is a beautiful sign. Stay home, protect our elders, save the rest. Some of the Native communities are really getting hit hard, as we hear from the news. Most of the California tribal settings, COVID has been slow to arrive, but that doesn't change what's happening in our big cities and in our urban Indian health centers. Next slide. So the spirit of our work, I always love to start with this to kind of ground us in our purpose. The values of respect and commitment to best practices in addiction medicine and recovery care. Whole person care includes medication, behavioral health, recovery support and case management, understanding the unique challenges our patients face, build strong traditional and cultural in communities, social determinants of health, housing, income, transportation, social support, and what your neighborhood is like, and always constantly changing the language and modeling the language of dignity. Often we're talking about destigmatizing or non-stigmatizing. I really love to frame the idea around changing stigma by making it a positive. What is the language of dignity that supports our patients to come in and get best possible care? Next slide. So the higher risk for serious illness, as we all know, COVID-19 has been really hitting all communities of color, and it really reflects and has really opened the door, opened the mind to the ongoing racism in healthcare, the ongoing health disparities just got amplified by COVID. It's not a new situation. It's just was one of the most powerful underlying conditions that our communities face. And as you can see, the risk is really high for the American Indian and Alaska Native, along with everyone else. So this is an impactful image. Next slide, please. So Matt care during COVID-19 in our tribal clinics, and Jeff has touched on this. There was a massive pivot in the middle of March to providing MAT care, medications for opiate use disorder care, and substance use care to the telephone and the video, to Zoom. DEA radically changed the rules about prescribing. It used to be that you could not get started on buprenorphine without an in-person physician or NP or PA visit. And then they said, okay, you don't need one. You can do it on Zoom. You can do it on all these different platforms, including FaceTime. So they really dropped the barriers around protective information. And then within a few days, they said, well, some people can't even get to a Zoom, so we are gonna let doctors initiate buprenorphine care over the telephone. So that was a radical shift and a change, and it happened very quickly. And hopefully it has been helpful. I don't know, we're still learning how these changes really impacted long-term care and outcomes. Behavioral health therapy is also being done via telehealth in best possible settings. It would be the video platforms, but also during telephone. And SUD counseling and case management calls are still not billable, but the care happens. And this is a sign greeting you at SNAC, one of our clinics, to wear a mask when coming into the clinic. Next slide. Changes and considerations in MAT care. With MAT patients receiving as much care as possible via remote ways using multiple platforms. So that was our primary goal, especially when the whole state was shut down, is minimal travel and in-person contact with best possible stability. That was the challenge. So the first thing that happened was we had to change the requirement in most of our programs for urine drug screens. And so those decisions were made by the teams and by the providers. Some teams just kept to it. You got to come in, you got to go to the lab, you got to do a drug screen. Other clinics said you're going to come in once a month. And other clinics said, we're not going to require a drug screen right now because things are just too urgent, and we want to minimize all contact. So really, there's been no clear approach. Every clinic, every provider kind of has figured out what works best for them. And a lot of it has to do with how much contact that individual would have to make in order to submit a drug screen. Coming into the building, checking in at the window, going into lab, all of those are direct contacts with patients that requires masking, hand sanitation, and social distancing. So things have been kind of figured out by now, and we're also very curious as to patients are not required to submit urine drug screens. Has that changed anything? Has it made things less safe for them? Are they going to surprise us with, more stability? And we'll know when we're on the other side of this, but right now the outcomes around opiate use disorder are not that great. And we'll touch on that in a minute. So also along with urine drug screens, weekly visits, we have had built into most of our phases of care that patients, when they're newly admitted to our programs, they get a 7-day supply, and then as they stabilize, which is often reflected in their urine drug screens, and they're attending their appointments as scheduled, we now have had to stretch out the length of the Suboxone prescription, which invites other behaviors, diverting or losing or selling. So we're also going to learn more about this as time goes on, but it was definitely decided to make sure the patient had their Suboxone, even if it meant going from a 7-day to a 28-day supply. And of course, that points to the diversion and the compliance. If a patient runs out early, it may be because they took 4 to 5 to 6 tabs in one day, not taking as prescribed and diverting as a common behavior that we have to plan for and redirect in our patients. Counseling needs and case management needs really changed. Substance use counselors are calling from their home laptops or calling from home. Case management needs are drastically changed. If our patients have unstable housing, that has been amplified. So we've just had to stay on top of those social determinants of housing, income, safety, sheltering have all radically changed. And really, there's been a decrease in care in most settings. Many clinics offer Zoom MAT groups with the breakout appointment for face-to-face MD visit. If there was already a good, strong MAT group happening in the clinic, the pivot to Zoom was kind of smooth. The best MAT groups are the ones where the patient's required to attend, and so they keep coming. The breakout room is wonderful for that face-to-face with the doctor and then back into group with you. If you want to know more about it, please reach out to me and we'll talk about that. We're designing that right now for the SNAC, the Sacramento Native American Health Clinic MAT program. Some patients have, and Jeff really touched on this, they have no or limited access to internet. They're remotely. Some patients, pay for their minutes, and they don't want to use their minutes for an hour call with a counselor. So we talked about those multiple challenges that we have to consider, and how do we take care of that patient. So the doc may be really giving them, a month's supply and hoping for the best, better than nothing. Next slide, please. So I just think this is a gorgeous mask. It's it's art, and I couldn't get that person's name on it, but this is like a designer. Looks like it was made out of one of the designer bags. Does anybody know, is that Gucci or who does that bag? Extra points if you can put that answer in into the chat. Life-saving importance of wearing mask when around others and socially distancing cannot be overstated. We all now have a daily, repetitive, never-ending reminder to wear masks. Yeah, so Rebecca Jarvie is the artist. Does anybody know who the handbag maker is in that picture also? So anyway, when we started COVID-19, the emphasis was on hand washing, hand sanitizer, and wear a mask so that, and basically the mask is, the purpose of the mask was so that you wouldn't touch your face. And now we know that airborne transmission is the primary way that this virus gets transmitted. So we're in a whole different headset about masks. Next, please. Mask up. So more on the mask. We wear a mask primarily to protect others, but if we don't touch our faces or rub our eyes, masks protect us from droplets and fine spray exposure also. So inhaling the droplets of another human being is the mask is a protector for that. So protection on both ends. This is what a lot of households do. We have developed a routine for going in and out of households so that you do the same thing every time. If I have a rare visitor, I greet them with hand sanitizer. Hello, how are you? And that's just what we do. If they have access to getting to the sink, if they can get to my sink, I'll have them scrub up. But I don't take a lot of chances with my own health and with the health of any other people that I come in contact. If we're going to do this, let's do it 100%. But having a routine, especially with people that come more than just once to your household, is really helpful. My grandchildren are all trained to sanitize, to wear a mask, and to socially distance. If you have people in your bubble, then the rules are going to be different, but wearing a mask in a house if you're visiting, if any risk at all. Next slide, please. Quick facts about the COVID-19. I think this is interesting information. Probably everybody who's on this webinar today knows all of this and then some. But the COVID virus is not a living organism, but a protein molecule covered by a protective layer of fat, which when absorbed by the cells of the ocular, nasal, or buccal mucosa, changes their genetic code and converts them into aggressor and multiplier cells. So the whole idea is that it's not a living organism. It doesn't respond to antibiotics. A lot of foaming, it says a lot of foaming in your hand washing is really going to break down that protective layer of fat, which is the idea. And the virus is very fragile, and any soap or detergent is best remedy. There's been some word out there about hand sanitizers, some of them having pretty toxic, one of the alcohol compounds is toxic. So pay attention to that if you have concerns. And any mix, 1 part bleach, 5 parts water directly dissolves the protein, breaks it down. So if we don't have handy wipes, we can make a mix of bleach and water to wipe down our environments as we go. Next, please. So flatten the curve. This is just a really great image from UCSF and the CDC. It doesn't have numbers, but shows how what flattening the curve means. No intervention, which is what we're struggling with now. We flattened the curve beautifully. And by the end of May, we decided it was time for a revolution. And we've been dealing with a lot of spikes in deaths and positive cases. So using our measures that we know work, hygiene and safety, social distancing, wearing a mask, cleaning surfaces, this is how those protective measures actually flatten the curve. So I think we're all pretty much on this piece of information also. Next, please. So the impact of COVID, and Jeff touched on this also, is that we are looking at a really big increase in opioid overdose deaths. A devastating rise. As Dr. Corey Waller said, we've lost all the ground we gained, which is really disheartening. So there's increased fentanyl in our communities. I spoke to one of our tribal council members recently, one of our reservations down south. They had 8 fentanyl overdose deaths in 3 months. Just huge loss. In the coming months, we're going to be really focusing more on fentanyl awareness and how we can change that. Our patients are losing connection with the support system. Often our patients will have one person who has been furloughed. It happens in countless ways. The safety net has never been really perfectly strong, and with something like COVID impacting how our clinics function, it impacts our patients. Increased financial instability, unemployment, furloughs, jobs lost. We all know how really hard this is on our American Indian and Alaskan Native communities. Tough stuff going on financially. Shelter in place has brought increased exposure to family substance use and dysfunction, child abuse, interpartner violence. There's always an ongoing conversation about making families stay at home together and in a household may prevent exposure to COVID-19, but now there's exposure to other dangers that happen in the household. We need to keep talking about this and understanding that that awareness about this issue needs our attention. Isolation and change in living routines. We know that the disease of addiction thrives in isolation, and change in routine sets people up, and this includes access to your drug of choice if you're still using. The harm reduction world has really had to adapt to keep as many people alive as possible, and it often involves how do we distribute syringes, how do we do outreach to people who are still using. Loss of family members and elders from COVID-19. This is especially an impactful loss in the Native communities. And really, and Albert's going to talk about this a lot next week, the loss of gatherings and the loss of ceremonies, passing ceremonies for those who have passed, and the elders have died, and how the community and the family has to adapt its response in saying goodbye. Next slide, please. COVID. So I wanted to give you an up-to-date reading. Today in California, we have had 475,305 positive cases. So that's 475,305 cases, positive cases in California. And we have had 8,715 deaths. The hot spots are LA Bay Area, Riverside County. I know that the Riverside team is here. Orange County, they keep changing them. Mo counties where I live have manageable COVID counts. I think my county, Nevada County, is under 300 positive cases. So we're hyper vigilant up here, hopefully, but it's been slow to arrive. I know it's been pretty slow to arrive in counties like Shasta and Humboldt, but all precautions must be applied. The inclination is to get COVID fatigue and let the guard down, or to just get careless. We're tired of this thing. Some promising new treatment for those with COVID-19, such as remdesivir. Early studies suggest possible shorter recovery time. A large, I didn't finish that line, but a large, the first 30,000 person vaccine trial has been started. If you're interested in volunteering to be in the vaccine trials, you can go online to do that. So the efforts to get the vaccines to us are progressing. And then here, this is a website. This is, we call it the COVID dashboard. It's how you can get all your information, statewide, county, citywide information. It's really an excellent tool that you can get online. That's the address. Next, please. So online 12-step programs also discussed by Jeff. There are tons of them. One of my favorites is the Medication Assisted Recovery Anonymous, which is just a wonderful recovery group, 12-step group for people who are prescribed medications to treat their addictions. And it is welcoming, non-judgmental, and offers lots of good 12-step recovery without stigma. They have a beautiful Facebook page for anyone who wants to join that. Send your patients there. You must send a request to the administrators, but it's an excellent Facebook page. Then there's NA, there's Narcotics Anonymous, phone line meetings. If you want, I think I've circulated a very comprehensive list of NA 12-step meetings, smart recovery meetings, Red Road Tribal Recovery. We have Telewell, we have I think we now have spiritual healing meetings 3 times a week. Is that true, Jeff?
Yep.
Okay, yeah. So we have a strong program that we offer, and it's well attended. And next week, Albert will really explore and touch on this and what's to come also. Next slide. This is just a beautiful white bison logo that I love. So we'll, yes, so Monica, yes, we'll be sending out our, you'll have access to these slides. Next, please. Safety first. This is my big campaign. I walk around with naloxone in my purse, in my pocket, because we have had a 13% increase of opioid overdose deaths, according to the CDC, 2020 over 2019. The counts are not complete, of course. The tremendous increase of overdose death means that we have to redouble or retriple our efforts to getting naloxone into the hands of every household. So I'm gonna, whoever's visiting this webinar today, I'm gonna really encourage you to check access in your clinics, in your communities, how we can do it better. And then here's the the website, which is the naloxone distribution project. It's very easy, 3 simple forms, and they'll send you boxes of it. We have Hannah at Sakui and Caroline and a few others at Crib. All you have to do is send them an email and they're going to ship you some naloxone. So make sure that you have plenty of literature to distribute on naloxone. I spoke with someone recently who said that it took 4 doses of fentanyl to save a life, not 4 doses of Narcan to save a fentanyl overdose. So if you're talking to me, you're probably going to start hearing about this pretty quickly. Next slide. So Hope Without Stigma and Dispelling the Myths. So Dispelling Myths is this is beautiful materials developed by Sakui and Crib, familiar probably to just about all of us. Hope Without Stigma is a pamphlet that is just about how to save a life, recognizing and preventing opioid overdoses. If you don't have one, please contact Sakui or Crib, whoever you're working with. And if they don't respond, reach out to me, I'll get them to you. Dispelling Myths is actually a fold out. If you open this up, there would be just a whole bunch of really useful information about medication-assisted treatment for opiate use disorder. It's really beautiful. Some of the best materials I've seen anywhere is coming from our California agencies. Next slide, please. Long-acting medications can be helpful in minimizing patient contact. This is a very big deal. If you want to see a patient once a month and keep them alive, you may want to think about Vivitrol, the XL naltrexone for opiate use disorder, alcohol use disorder. The injections are not easy, but we really need to let our patients know that this is available to them. Sublocade is a monthly sub-Q injection of buprenorphine, direct buprenorphine, also very helpful. And Probufene is something that I've been learning quite a bit about lately, working with the makers of Probufene. It is an implantable, there are 4 rods that are implanted in the upper inner arm, similar to birth control implants. Patient must be stable on sublingual buprenorphine, and the dose is 8 milligrams a day, but you get your dose twice a year. And for some patients, that really works well. So let me know if you need any help in setting up better access to these medications. Usually it requires one of their sales reps, but they're very good at educating and supporting the process. And also, if you have any billing questions, how do we bill for these? Medi-Cal pays for them or not? If you want to bring this into your clinic, give me a call, okay? Next slide, please. Going forward, Tribal MAT 2.0, what to expect. We're going to be hearing more about it in the first weeks of August, how we're going to do this. Tribal MAT 2.0 is going to focus more. We're going to make traditional cultural recovery central to MAT care. We've been very focused the last 2 years of getting waiver doctors in the buildings and getting the medications to the patients. And now we're going to really build strong, culturally centered treatment programs. And there are some out there already that will be leading the way with us. Integrating stimulant use disorder into MAT programs is going to be a huge challenge. Cocaine and meth in most of our clinics, it's more likely to be methamphetamine. The state and SAMHSA and all the people that are sending us money want to start figuring out how to screen for and how to build treatment plans, pathways of care for our patients struggling with stimulants. Fentanyl awareness programs, I just touched on that really briefly. That's also going to be very emphasized in 2.0. And California will be developing a tribal learning collaborative, and we are going to all become learners together and teachers together. And there'll be more on that. This is something that Coco has been attending every month, every week. The Indian Country Echo COVID reports is every Monday at noon if you want to sign up. That's a good thing to do. Coco is a really excellent resource for lots of information, but very specifically about Indian Country Echo. You know, is it okay to do sweats during COVID? Questions like that.
Awesome. Thank you, everyone. Thanks, Katie.
Have a beautiful day. Thank you all. Bye-bye.
Bye.